So patients that are not or no good candidates for liver transplantation or liver resection are in general patients that have intermediate stage disease. And here we have two studies that have shown that transarterial chemoembolization, TACE, is a good treatment option which can improve survival. And with this study, TACE has made it to the most commonly used treatment option, treatment modality in all over the world for patients with HCC. So the question is, who is a good candidate for TACE? I think the clinical trials were done in a very selected patient population. So these were patients that really had a good liver function, that had small tumors, and that did not have major vascular invasion or extrahepatic disease. And if you have such a selected patient population, you can really achieve impressive results with TACE. On the other hand, if the patients have larger tumor or advanced liver disease, you might lose a lot of this advantage you see in patients with smaller tumors and better liver function.
We know that surgery is the only way to cure this disease. A minority of patients are candidates for a straightforward liver resection, at least in the United States, where we see most of the liver cancers associated still with hepatitis C, so they do have significant cirrhosis. But liver transplant does play a big role. Candidates for liver transplant have to have certain tumor characteristics. Ideally, they're within Milan criteria, which is 1 tumor less than 5 centimeters or 3 tumors less than 3 centimeters. In certain regions, they use UCSF criteria, which allows for tumor burdens up to a total of 8 centimeters with multifocal disease. But regardless, the question is if a patient is beyond Milan criteria or a patient has a tumor that's too big just to be resected, is there a way to make them smaller? And while the data is not clear, often chemoembolization procedures are done to try to shrink the tumor, or even a radiofrequency ablation to try to decrease the tumor burden to make them resectable or to put them back within Milan criteria. Of all the treatments we use in liver cancer, for patients that present to the clinic, probably liver-directed therapies play the biggest role because most patients do present with relatively preserved liver function, either Child-Pugh A or early B, and liver-confined disease. And chemoembolization, which involves going through the femoral artery into the hepatic artery and injecting drugs and embolizing the vessels that are feeding the tumor, plays a major role in the management of these patients. It's been shown to improve survival. Other approaches that are liver-directed, such as radiofrequency ablation, play a significant role. The choice between those two approaches really depends on tumor size and tumor location. But both of them have been shown to improve survival. The challenge becomes that they're not curative. So if a patient has a liver-directed therapy, their tumor generally will recur or continue to grow. And whether or not they will be a candidate for another liver-directed therapy really depends on the location, their disease-free interval, and their underlying physiology of the liver. The real challenge, I think, in practice is recognizing that chemoembolization's outcomes are really optimized by patient selection. And for patients who have symptomatic liver cancer or have invasion of their tumor into the liver vasculature, those are areas where outcomes with chemoembolization are not as good as when those characteristics are not present. And that is where many of the guidelines suggest going to systemic treatment.